In this video, we'll learn about the diagnostic criteria for polycystic ovarian disease. The diagnostic criteria for PCOS most commonly used worldwide is Rotterdam criteria 2003. The other criteria include NIH criteria in the year 1990. It was given in the year 1990. Androgen excess and PCOS Society gives again another criteria for diagnosing PCOD. But remember, most widely accepted is Rotterdam criteria 2003. According to this, it has three criteria, out of which at least two should be present to diagnose it as PCOS. First one is oligo or anovulation, infrequent or absent ovulation. So usually patient presents typically with irregular menstrual cycles, cycle duration of about approximately more than 35 days or less than 8 cycles per year. Meaning, see now if a girl has a regular menstrual cycle, 12 cycles should be there per year, right? So what happens now is it is less than 8 cycles per year. So it means that the cycle duration for each month is prolonged. So this is mainly the first one. Criteria is mainly based on the history. So she has a irregular menstrual cycle or oligomenorrhea here, which indirectly indicates there is an ovulation, right? So now another criteria is there should be clinical or biochemical signs of hyperandrogenism. So clinical signs would be if the patient presents with hirsutism, acne or alopecia. Biochemical presentation would be you need to estimate there is elevated serum androgens or not. You can test for testosterone as well as DHEAS. The next criteria is based on ultrasound findings. There should be more than or equal to 20 follicles in each ovary measuring about 2 to 9 mm in diameter, and the volume of each ovary should be more than 10 centimeter cube. Remember, follicle count threshold may vary depending upon the ultrasound technology, because these days the technology is improving, so even the smaller follicles are found. So that is why the follicle count, no, initially some books mention more than 12 follicles in each ovary is considered as a diagnostic criteria, but more than 20 follicles is an accepted finding. So diagnostic criteria for PCOS is oligo or anovulation is the first one. Second is clinical or biochemical signs of hyperandrogenism. Third one would be polycystic ovaries found on ultrasound findings. Okay, so at least two should be present. But remember here, two out of three criteria should be present. At the same time, exclude other disorders. See, other hormonal disorders like congenital adrenal hyperplasia, androgen secreting tumors, Cushing syndrome, thyroid dysfunction, hyperprolactinemia, all these can present with signs of hyperandrogenism, right? So exclude the other disorders. After that, at least two of the three criteria what we mentioned should be present. The NIH criteria and the androgen excess PCOS criteria, no, they also almost mention the same thing, but the importance is given to either one of these criteria. So now if you see the NIH criteria, it requires both oligo or anovulation and clinical or biochemical signs of hyperandrogenism, but ultrasound criteria was not used in this definition. See, as you can see the year, no, this was criteria was given in the year 1990. So those days ultrasound was not given that much importance. So they mainly based on the history and clinical examination findings and diagnosis, lab investigations. They were mainly dependent on that. So it requires, so according to NIH criteria, they required both oligo or anovulation and clinical or biochemical signs of hyperandrogenism. So ultrasound criteria was not given that importance. Now, if you look into this androgen excess PCOS society criteria, here as the name itself is telling, it is an androgen excess PCOS society criteria. So they, for them, hyperandrogenism is mandatory to call it as PCOS. Clear? It can either have the ovarian dysfunction, or maybe oligo or anovulatory finding, or maybe the polycystic ovarian ultrasound. At least one of them should be present. But for them, mandatory is hyperandrogenism. So if you look into this, some articles, no, they had mentioned in 2006, the Androgen Excess Society again made hyperandrogenism central to the diagnosis of PCOS, while affirming the relevance of ovarian morphology in the diagnosis of this syndrome. Meaning here, for them, hyperandrogenism takes the central role in diagnosing it as PCOS. So the AES guidelines require the presence of hirsutism, that's a clinical presentation of hyperandrogenism or biochemical hyperandrogenism, as well as either one of them. Either you have patient can have oligo or anovulation, or the polycystic ovaries in ultrasound. So that is your polycystic appearing ovarian morphology is an ultrasound finding. So for them, according to AS guidelines, hyperandrogenism is the main role. Now, if you like now by this introduction you would have understood the patient should have either have oligo or anovulation, then either should have biochemical hyperandrogenism, clinical hyperandrogenism, or polycystic ovaries in ultrasound finding. So now if you see here, what exactly do I mean by biochemical hyperandrogenism? Meaning the patient presents with increased testosterone. It can either be a total testosterone is higher or free testosterone is higher. Free testosterone meaning the testosterone which is not attached with any plasma proteins in the blood. Total meaning it estimates both free testosterone as well as the bound testosterone, the testosterone which is bound with the proteins. Or sometimes using the free testosterone, they calculate few indices, that is FAI and BIOT. Meaning here elevated total of free testosterone or calculated indices, any of them, at least like one of them should be higher here. So additional markers also like DHEAS or androstenedione can also be considered. Now the question here is what is FAI, right? It is nothing but free androgen index. Okay, it is a ratio that estimates how much free testosterone is present in the blood, or the active form, how much is present. Okay, normally there's a formula for FAI. Using the free testosterone value, they can calculate the free uh, this FAI, right? So that's a free androgen index can be calculated. This is helpful because most of the testosterone which is bound with the proteins, no, like globulin and all, they are inactive. So there's no point in calculating how much of total testosterone is there. Usually it is a free testosterone which is physiologically active. So what is BioT? BioT is nothing but bioavailable testosterone. Remember, this bioavailable testosterone includes free testosterone along with a testosterone which is bound to albumin. Remember, if it is bound with globulin, it becomes inactive, but the testosterone which is bound with the albumin, it is bioavailable testosterone. That is because from the albumin, no, this testosterone can easily dissociate and form a free testosterone. That's why the free testosterone and the testosterone which is bound with the albumin, we together call it as bioavailable testosterone. So it gives a more accurate measure of the testosterone that can act on tissues. So when these values are increased, it tells you that the patient has biochemical hyperandrogenism. Now, to call it as a clinical hyperandrogenism, I told you initially that the patient should have hirsutism, alopecia, and acne and all. Now, the question is, how do I call a person, like, how do I know that patient has hirsutism, right? For that, again, there is a criteria which is called a modified Ferriman Gallwey score. If it is equal to or more than 4 to more than or equal to 8, then we call it as the patient presents with clinical hyperandrogenism. This I'll tell you in the next coming slides. Okay, what exactly is the score, or how do I diagnose clinical hyperandrogenism? Oligo or anovulation, as I already mentioned, the patient will present with oligomenorrhea. The cycles are more than 35 days apart or less than 8 cycles per year. So PCOD or polycystic ovarian morphology also, as I mentioned, 20 follicles per ovary in either ovary. One of them at least can have more than 20 follicles, and the volume of each ovary is more than 10 centimeter cube. Now, to understand this better, no, what we'll do is we'll understand what is a normal ovarian volume. Okay, normal ovarian volume is around in between 6 to 10 centimeter cube. So if the volume of one ovary increases more than 10 centimeter cube, it indicates that the ovary is enlarged, which can be seen in PCOS. And what is the normal, how many follicles would normally be there? Okay, normal ovaries will have up to 12 small follicles per ovary. If it is more than 20 follicles per ovary, then it is considered as polycystic ovarian morphology. I'll repeat again. In a normal person, up to 12 small follicles per ovary is an accepted finding. If it is more than 20 follicles per ovary, then it is considered as polycystic ovarian morphology. Now we'll move into this modified Ferriman Gallwey score, what exactly it is. Okay. So the modified Ferriman Gallwey score is a clinical tool which is used to quantify hirsutism, because see, hair is just distributed in a female, right? Like in a face and all. That's what we assume it's hirsutism. But how do I quantify that? Okay, that is nothing but excessive hair growth in women in a male-like pattern is what is called hirsutism. It is commonly seen in PCOS and other androgen excess disorders. So now in this, to calculate the score, 9 body areas are evaluated for the terminal hair growth. That is upper lip, chin. This is in the face, then chest, then upper abdomen, lower abdomen, upper back and lower back, upper arms and thighs. So all these areas, now we need to examine if the patient has any hair growth. So depending on the hair growth, each area is scored from 0, which is no hair, to 4, that is frankly virile hair growth. So from 0 to 4, we keep scoring all these 9 areas. Okay, upper lip, chin, chest, upper abdomen, lower back, upper arms and thighs. So now we are examining 9 areas. The maximum score each area can get is 4. So 9 4 is 36. So the maximum score which we expect is 36. Now what is the diagnostic cutoff for this MFG is nothing but modified Ferriman Gallwey score for diagnosing hirsutism. Okay, remember there's no universal cutoff, and the threshold varies by the ethnic background. If it's a Caucasian population, more than or equal to 8 score is considered as hirsutism. In an Indian or a South Asian population, more than or equal to 6 to 8 is considered hirsutism. East Asian, it is 4 to 6. Mediterranean or Middle Eastern, 8 to 10. So what you get from the slide is there is no universal cutoff, and it varies according to the ethnicity of the person. But in general clinical use, no, remember, if the score is 6 to 8, it is suggestive of clinically significant hirsutism, again depending on the ethnicity. But remember, if you're calculating these scores for a patient and it comes somewhere close to 6, above 6 or above 8, then you can consider that the patient has hirsutism. Again, some books have mentioned this grading: mild, moderate or severe depending upon the score. Remember, the maximum score possible is 9 into 4, so that is 36. But just above 6 to 15, value between 6 to 15 is considered mild hirsutism, 16 to 25 is moderate, more than 25 severe hirsutism. So now you know how to detect clinical hyperandrogenism based on the hirsutism findings. So just to summarize what we learned till now, we studied about three criteria. One is Rotterdam criteria, which is most commonly accepted, NIH criteria, and AE-PCOS criteria. Remember, Rotterdam criteria is the most commonly or widely accepted one. It has three criteria, that is oligo anovulation, hyperandrogenism, polycystic ovaries when you do it's as an ultrasound finding. At least 2 out of these 3 should be present, and also remember, exclude other causes of uh, hyperandrogenism. Okay, NIH criteria is according, this is the old criteria, so ultrasound was not that prevalent, so you can based on mainly the history and by the clinical findings you diagnose this criteria. The next one is AE-PCOS criteria. In this, main mandatory finding is hyperandrogenism. Then one of either of the oligoanovulation or PCOS findings or ultrasound findings may be present. So if you have understood the diagnostic criteria and you feel like if it helps your friends, please share it to your friends.